Hi everybody. I think a lot of people in the audience already know me. I'm Charles Edelstein. I'm at the University of Colorado. I'm a basic science researcher, and I also have PKD Center of Excellence, one of the physicians there. So I'm going to talk about uric acid. You heard something about uric acid in the previous talk with the ketogenic diet. I'm going to show you that raising uric acid with a uricase inhibitor worsens polycystic kidney disease in rat and mouse models. There's my disclaimer, disclosure. There's my speaker bio. I've been at the University of Colorado PKD clinic for more than 20 years. And let's start the presentation. So this is how uric acid is formed in the body. So you ask, where does it come from? It comes from dead cells in the body. There's 50 billion cells in our body that die every day, 50 billion. And what I read is that in a year, the whole weight of your body is replaced by new cells. So if you weigh 70 kilograms, in a year you get 70 kilograms of new cells replaced. So all those dead cells have to go somewhere. So they're converted into nucleic acids, hypoxanthine, xanthine uric acid. The enzyme that converts hypoxanthine to xanthine to uric acid is an enzyme called xanthine oxidase. And the drug that is mostly used to block xanthine oxidase is allopurinol. Some of you may be on it already. So that decreases the formation of uric acid. Now, the sad thing happens. So there's certain things that can raise your uric acid. One of them is high fructose corn syrup, which we have in all our sodas. The other thing that can do it, you just heard about, is a ketogenic diet. Because a ketogenic diet, you have less fat, but you have a lot of proteins. And proteins are what are converted into uric acid. So one of the side effects of a ketogenic diet is increasing the uric acid. Oh, sorry. What other things did I say over there? I can't see from here. Meats, diet, shellfish, shrimp, anchovies. I was just in Italy and I had a beautiful salad niçoise that was full of anchovies. Sure, my uric acid level went up. And shellfish, shrimp. So there's a lot of things that we eat that can raise uric acid. So now, what happens to uric acid when it builds up in your body? So non-humans, including mice, rats, monkeys, right up the chain to even the biggest gorillas close to humans, they have an enzyme called uricase. So they can convert uric acid into allantoin. And allantoin is a very benign substance. In fact, it's in most of our skin creams, allantoin. So they have uricase. They don't get bad things. We don't have uricase, so we get gout. You won't see gout in animals or dogs or cats, and we get kidney stones from high uric acid. Now there is an inhibitor of uricase which we've used. I'll show you the data. It's called oxalic acid. So we can take animals and we can block the uricase with oxalic acid, and then we can increase the uric acid in rats and mice, because otherwise we can't study high uric acid in preclinical studies because all the rodents have very low uric acid level. So we have a way of raising the uric acid by blocking the uricase. And I'll show you that data. So here are the potential mechanisms by which uric acid can increase cyst growth. There has been, a lot of you know about crystals forming in the urine, mostly Thomas Weems's work. It showed that calcium oxalate can cause crystals, which can worsen cyst growth, but uric acid has the potential to form crystals as well. Soluble uric acid can increase oxygen radicals. You can activate something called the inflammasome. You can cause blood vessel injury. And high uric acid has been associated with higher blood pressure. There have been a lot of studies looking at the association between uric acid and cyst growth, by the way. I'm just showing you one of the positive studies, but there have been some studies which have shown an association between high uric acid levels and cyst growth, and other studies have not shown an association. This is one of the studies from the University of Colorado, 600 PKD patients from the PKD database that showed that higher serum uric acid levels are independently associated with hypertension, larger kidney volume, and an increased hazard ratio for end-stage kidney disease. So you can see the higher the uric acid, the lower the GFR. The higher the uric acid, the higher the kidney volumes, and on an adjusted heart hazard ratio for prediction of ESRD, one of the factors that came up was a uric acid level. But I just want to tell you there have been studies that have shown the opposite. So I'm just showing you one of the studies from University of Colorado. So it's only an association, right? There's no causative effect. So as I said, rodents have very low baseline uric acid levels. So our aim was to determine whether raising the uric acid in rodents using the uricase inhibitor called oxalic acid is associated with worse PKD. So we used two models. We used the rat model, PCK rat, which is a PKHD1 gene model of autosomal recessive PKD, and we used the PKD1RC mouse, a hypomorphic PKD gene model. We increased the uric acid with the uricase inhibitor oxalic acid, and we also did some preliminary studies lowering the uric acid using oxypurinol, which is a xanthine oxidase inhibitor. So these PCK kidneys, this shows xanthine oxidase staining, which is brown in the kidney tubules. In PCK rats, there is a lot of xanthine oxidase around in these kidneys, in brown in the tubules. Actually less around the cysts, but a lot in the cortex. So remember, xanthine oxidase is what converts all these purines and proteins to uric acid. We treated the rats with the PCK rats with oxalic acid, and that caused an increase in the uric acid levels. I just want to tell you that measuring uric acid in rodents is not as easy as it sounds. We did it by HPLC. The results are variable, but there's always an increase, but the numbers are often different. So it's a very sensitive assay. And actually, there was less allantoin, meaning that when the uric acid builds up, less of it's converted to allantoin. And this shows that oxalic acid increases cyst growth in the PCK rats. So the kidney weights were higher, the cyst volume was higher, the cyst area was increased, it wasn't quite significant. The cyst count was increased, not quite significant. The BUNs and creatinines were the same. So it looked like there was increased cyst growth in the PCK rats. This is kind of representative kidneys that show that oxalic acid increases cyst growth in the PCK rats. In the PCK rats, the cysts are mostly in the medulla, and these are oxalic acid treated kidneys. We saw some huge increases in cysts. You can see here that virtually the whole medulla is replaced by cysts, and these were the oxalic acid treated rats. Now we looked at the PKD1RC mouse, and we actually stained for xanthine oxidase, and interestingly, it looked like in the normal tubules, there was increased staining for xanthine oxidase. Remember, xanthine oxidase is what produces uric acid, and on quantitation, the staining was increased. So it's interesting because one of the biggest stimulants, things that increase xanthine oxidase, is hypoxia. And polycystic kidneys are hypoxic because of all the cysts that form hypoxia. So it's possible that the cysts in the mouse are causing hypoxia, which is increasing the xanthine oxidase in the normal tubules. So this shows that oxalic acid increases cyst growth and actually worsens kidney function in the PKD1-RC mouse. The kidney weights were increased, the cyst indexes were increased, the cyst size was not, but the cyst number was, suggesting that maybe there's increased number but not increased size, meaning maybe you're forming new cysts rather than existing cysts are getting bigger by giving oxalic acid. And in the mice, the creatinine was increased, the uric acid was increased. It wasn't statistically significant, but as I said, we're having some difficulty measuring the actual uric acid accurately. And this is a cross-section of these kidneys, so you can see the oxalic acid-treated kidneys have more cysts than the vehicle-treated kidneys. So then we wanted to see if we could do something with oxypurinol. So this, which is a xanthine oxidase inhibitor, much like allopurinol. So this slide shows that oxypurinol decreases the increase in kidney weight and cyst index that's induced by oxalic acid. So we had two groups of animals. One group got oxalic acid to raise the uric acid level, and then the other group got oxalic acid plus oxypurinol to decrease the uric acid level. So in rodents, we increased the uric acid with oxalic acid, and then we gave oxypurinol to decrease it. And in some preliminary data, it looked like in the RC mouse now, the kidney weight was lower, the cyst index was lower, the cyst size was lower, not that significant, the cyst number was decreased. And here we saw a huge decrease in the uric acid levels when we gave oxypurinol, which is a xanthine oxidase inhibitor. And this shows representative kidney, so there's less cysts in the kidney that got the combination of oxalic acid and oxypurinol. So what is the mechanism of how uric acid is increasing cyst growth? These are the possible mechanisms that I've mentioned before. I'll just go through: formation of crystals, reactive oxygen radicals, activation of the inflammasome, endothelial injury, activation of the renin-angiotensin system causing hypertension. We know that allopurinol decreases hypertension. So we did a panel of pro-inflammatory cytokines in the mice, and it seems like the animals treated with oxalic acid that had a higher uric acid level had high levels of some of the inflammatory cytokines. This is IL-5, IL-4, KC. For those of you that come from Kansas City, it's not Kansas City, it's actually interleukin-8. His other name is CXCL1, but they call it KC in mice. There was an increase there of KC. So that is one of the most potent pro-inflammatory cytokines, is CXCL1. That was increased in the kidneys of the oxalic acid-treated mice. We don't know if that's causative or not, because we have to block it to show whether it's causative or not. This is what we were looking forward to doing, is looking for crystals. So this slide shows that worse PKD in the rats and the mice induced by oxalic acid is independent of crystalluria. So as a positive control, we got sections from Richard Johnson, who has the most potent uricase inhibitor that raises the uric acid levels massively in rats and mice. And as a positive control, yes, we saw crystals of uric acid. We looked through these mouse kidneys and rat kidneys. Here's the low power, here's the high power. We did not see any crystals. So we think that the worst PKD induced by increasing uric acid is independent of crystals. Next, we looked at the inflammasome. So caspase-1 is a marker of the inflammasome. So this slide shows that oxalic acid did not affect caspase-1, a marker of the inflammasome. So we immunoblotted for caspase-1 in OXO-treated or vehicle-treated rats and in mice, and there's like no change in caspase-1. So in summary, increasing serum uric acid with oxalic acid results in an increase in kidney weight and cyst index in PCK rats and PKD1 RC mice. The effect seems to be independent of crystalluria. Oxalic acid does induce a pro-inflammatory cytokine storm, it looks like, in the kidneys. So in conclusion, maybe a clinical trial of lowering uric acid in PKD patients is warranted in the future. That's my contact information. You can speak to me afterwards if you need it in more detail. Questions? Oh, I didn't put this code in. What is that? I'm not that code. What is this code?
The code is for the online Q&A, but people can scan. So that is something that the PKD Foundation did. Thank you so much, Charles.
Social security number and things.
No, no,
checking.
it is not, Charles. So thank you so much for your talk. We are unfortunately over time. So if you do have questions for Dr. Edelstein, please find him afterwards. Or if you also have questions on the keto study, the author will be available on the PKD Foundation platform, and she promised she will answer these questions rapidly. So please just go to the PKD Foundation website and go into the platform for today's conference and ask your questions there, and she will be responsive. And yes, Charles will be around. So to stay on time for our session here and moving on to the other session, our last speaker on the dietary interventions is Dr. Courtney Steele, and she's also from the University of Colorado Anschutz Medical Campus. So thanks, Courtney.
All right. I know we're shy on time, so I'll try and kind of talk fast. So thank you for the PKD Foundation for inviting me. My talk today is going to be on visceral adiposity and progression of ADPKD patients from the Tempo 3-4 trial, which was a cohort study. I think it worked. Did I mess it up? I'll just click. All right, so here's the activity disclaimer from the PKD Foundation. Before I present any data, I just wanted to disclose that the study was done in collaboration with Otsuka Pharmaceuticals and Aerobics Life and the University of Colorado Medical Campus. And, well, so I'm going to skip my background, but you guys can see, just for the sake of time, that way we can kind of go through. If you have any questions or anything, feel free to reach out. In general, prevalence of overweight and obesity is increasing. So on the left here, you see in recent decades, BMI in ADPKD patients has been increasing similar to the general population. And then shown on the right here is data from a large ADPKD cohort study that participate in the HALT study, specifically the PKD trial, compared to general population data hosted by the CDC. So you can see both show a high prevalence of overweight and obesity, about nearly 2/3. So annual percent change in total good volume was greater with increasing body mass index. We used two trials for this, so the HALT PKD study, and then we found similar results in the Tempo 3-4 study. The relationship persists, this relationship, even when correcting for covariates in these regression models. In general, an increase in abdominal adiposity elevates pro-inflammatory cytokines, including IL-6, TNF-alpha. Pro-inflammatory cytokines are elevated in patients with ADPKD, so cytokines have been shown to activate pathways such as NF-kappa B, leading to increased cyst growth. Adipocytes also produce adipokines, such as leptin that increase with obesity and adiponectin that decreases with obesity, acting through the AMP pathway as shown there. Interventions to reduce adiposity with obesity, of course we know surgical interventions, lifestyle interventions, including physical activity, and dietary interventions have been common to reduce adiposity. So diving into the Tempo 3-4 trial, which many of you might be familiar with, but it was a tolvaptan trial. In general, the study design was multi-center randomized, double-blind, placebo-controlled. It was a 3-year trial. The inclusion criteria, this is brief because you can look at the main trial, but age is 18 to 50, total kidney volume was greater than 750 milliliters, and creatinine clearance was greater than or equal to 60. So the intervention was 3 years long. Participants were randomized to placebo or tolvaptan. The main measurements that I'm going to focus on for this presentation is MRI imaging, so total kidney volume in the main trial. And then what we did for this abstract and this secondary analysis was measure visceral adipose tissue. So diving in to the Tempo 3 results. So baseline characteristic of study participants from Tempo 3-4, according to the 3 tertiles that we split up for visceral adiposity volume. So you can see each quartile's baseline characteristics there. And then here's where, I guess, the nitty-gritty of this study comes. So with pre-processing and manual segmentation of T1 coronal images, so we're using MRI images here, and then we're pre-processing the coronal series based on these kidney masks to extract volumes to evaluate the potential surrogate marker of body composition or visceral adipose tissue. So to explain this briefly, a slab around the kidneys was selected considering the extreme points. So the y-axis of the kidney contour, so they're using a 10 pixels above and below. So you can kind of see in that image A where the slice is determined, and that's 10 pixels above and below the extremes. And then what I will give credit to my mentor, she's away right now. She went in and manually did the manual segmentations for this. So you can kind of see in that lower picture, figure B, she went in for 358 images and manually highlighted the difference between the regions of visceral, subcutaneous, and then muscle. So in the color scheme here, visceral adipose tissue is in green, and I'm sorry it's not playing as well on the slide there. And then you can kind of see the lighter blue is subcutaneous fat, and then the darker blue is muscle. So with that, with the images, Tempo 3-4 was about 1,400 patients. So the images that had, well, the participants that had MRI values were included in the study, so about 1,077 participants. And then she went in and manually segmented, and what happened then, and don't ask me the specifics of creating an artificial intelligence platform. Sorry, that's way over my head. But artificial intelligence was used then to dictate all the visceral adiposity in all the other images, so about 1,000 MRI images. And then to show this annual change in total kidney volume according to baseline visceral adiposity, as expected, baseline visceral volume increased significantly with increasing BMI, the highest visceral adiposity in individuals who are obese. Here are box plots of annual percent change of total kidney volume are shown according to the tertiles, so all 3 tertiles of baseline visceral adiposity. On the panel in the left, panel A, it's the total cohort, and then panel B represents it's split up by groups, so either tolvaptan or the placebo group. You can kind of see a stepwise progression with increased visceral adipose tissue. There was a greater annual percent change in total kidney volume. So here, this association of visceral fat volume with annual percent change in total calorie is displayed graphically by a spline plot. So the knots are set at 25, 50, and 75 percentiles. And before I get asked this question, we did account for a sensitivity analysis. So all those extreme values later were excluded and the associations remain. So that comes into play with the next graph. So visceral adiposity and annual change in total kidney volume. There was a significant three-way interaction among adiposity group, so either placebo or tolvaptan, and time for the outcome of annual kidney growth, indicating the efficacy of tolvaptan was attenuated with increasing adiposity. So, and this interaction persisted even when we excluded the extreme values or the outliers of greater than 2,000 milliliters of visceral adipose tissue. So these are receiver and operator curves comparing visceral adiposity to adjusted BMI as predicted by greater than 70% or 7% annual change in total kidney volume. So panel A here is the total subjects, whereas panel B is normal weight individuals, and panel C is overweight in the corner there, and then D is obese. So what's important to get out of these graphs is you can see normal weight in the normal weight panel. Visceral adiposity was a better predictor of BMI because they're separated. You can kind of see that relationship exists, that would be a main primary driving factor in especially normal weight individuals, whereas the lines are closer in C and D. So in general, in conclusion, visceral adiposity can be quantified by MRI via artificial intelligence and mapping. Visceral adiposity independently associated with rapid kidney growth, improvements of classification of rapid progression in individuals with specifically a normal BMI, as we saw in those ROC curves. And then in general, tolvaptan efficacy decreased with these results with increasing visceral adiposity. And so here is my contact information. Dr. Kristen Nowak is my mentor. She's away right now, but she's happy to answer any questions, I'm sure, too. And Diana George is our main recorder, and thank you for the PKD Foundation. And I'm happy to take any questions. This was supposed to be a flyer. I have a flyer for recruitment if anybody wants to participate in any of our studies. And thank you for everything. Hopefully I stayed on time. I'm over, sorry.
Thank you so much, Courtney, and you were great on time, so no worries there. We do have time for questions, so I will have them.
I just have a comment. What I find, this is really exciting, and as you know, the GLUT1 inhibitors like semaglutide or Ozempic can cause a 20% loss of visceral fat. So if visceral fat is truly related to PKD, if you lose 20% of your visceral fat, I would think that there should be some effect.
That's the next
Correct?
study, isn't it, Charles? They're looking at SLG2 inhibitors soon.
Thanks for the comment. Any other questions? Yes, absolutely.
You had a number of data points where you're actually showing decreases in TKV in both groups, the tolvaptan and the control group. Do you attribute that to actual decreases or the artifacts of the measurement techniques or what?
It would be hard to tell from this data set, to be honest, to infer anything like that. But based off the data presented, those outliers could be true outliers, or it could be true to measurement. Yeah, basically, I wouldn't be able to infer based off this data set whether, yeah. And it's also a secondary analysis, so that makes it tough to go back, yeah.
Thank you, Kat. Beautiful data. Congratulations. Is this, you think, unique to PKD, or could a similar association emerge in non-PKD CKDs? And so, as a relation to that question, do you see a correlation with eGFR? You've shown kidney volumes, but what about GFR?
That's a great question, and I knew you might ask that. So right now, Aerobics is running that data for us because we got a comment from the reviewers. So I will disclaim that this is in review for paper. So one of the comments was to add eGFR. So that data will be available in the manuscript. And then whether it's specific to ADPKD, I mean, the track we are on is related to PKD, but I don't think it's anywhere. We can't really say if it's completely PKD, but obviously with obesity and things, we see pro-inflammatory cytokines. So the same thing could apply to the general population.